I welcome you all, wonderful learners. So, today we are going to have a discussion on pyramidal tracts. Okay, so today's topic will be pyramidal tracts, that is the corticospinal tract. So, before that, let me tell you, you can subscribe the channel, you can share it, and also log on to the Telegram group, that is Physiology Synapse to Success, for the notes which I am taking on. Now, whenever you study any tract, you have to know its origin, you have to know its course, you have to know its termination, its function, and definitely a word regarding its applied. So you can see that this tract, which will be a upper motor neuron type of a paralysis leading to if there is a lesion with the pyramidal tract, and this is the lower motor neuron. So the pyramidal tract, when we will study the pyramidal tract, we will see how it is originating from the cortex, passing through the posterior limb of the internal capsule. How is there going to be the arrangement of the fibers when it passes through the different areas of the brain? After the internal capsule, it will be the midbrain, the pons, the medulla, and finally, how does it terminate in the spinal cord? So this is the way the descending tract has to be elaborated. You can always write in the form of a flow chart. Now, it is the longest tract, something very interesting to be known, that it is the longest direct motor tract, which is taking its origin all the way from the motor cortex, and it is terminating on the anterior horn cells of spinal cord. So the anterior horn cells or the ventral horn cells of the spinal cord. Very interestingly, the total number of fibers in this tract are about 1 million, right? But 97% of the fibers are less than 4 micrometer in diameter, which are conducting tonic signals to the motor areas. So out of the 1 million, 97% of the fibers are just less than 4 micrometers, which are conducting tonic signals to the motor areas. The 3% of the fibers which are coming from the giant cells of beans, which is especially present in the area number 4, that is the primary motor cortex of the spinal cord, with a diameter of 60 micrometers and conduction velocity 70 meters per second. That means the pyramidal tract is mainly composed of slow conducting fibers, out of which 50% are unmyelinated. So descending tract hai, which is supplying the voluntary muscles, but it is mainly consisting of slow conducting fibers, out of which 50% are unmyelinated. Now, though we call that this pyramidal tract, it is a motor tract. You will be surprised that 40% of the fibers in the motor tract are coming from the sensory areas. That means 40% of the fibers are sensory, which are coming from the area 3, 1, 2, the primary sensory areas, and area 5 and 7, which are the association areas. 30% of the fibers from the premotor area and another 30% of the fibers from the primary motor area. This is also an important MCQ, that what percent of the fibers are sensory. Now we've seen that it takes origin from the cortex. Once arising from the cortex, these fibers, they're going to converge down towards the brain stem as a radiating mass of fibers, like a hand fan. So they radiate downwards, they converge in the form of hand fan, and therefore it is called as corona radiata, and they are going to reach the internal capsule, right? So the corona radiata from the cortex is coming into the internal capsule. In the internal capsule, it lies in the genu, and it lies in the posterior limb of the internal capsule. There is a very, very specific arrangement of the fibers in every part of the brain. This will be very important when clinically you will see that if the anterior part is involved, what fibers will be affected, and so on. So from anterior to posterior, the fibers, when they are in the internal capsule, they show a very specific arrangement. That is anteriorly head, followed by shoulders, elbow, wrist, fingers, trunk, hip, knees. That means most posteriorly are the toes. So the most anterior is the head and the most posterior are the toes. After the internal capsule, it is going to pass through the midbrain, where the fibers are ventral to the substantia nigra. And the presentation over here is that the head is presented medially, the legs are presented laterally, while the trunk is between. So head is medial, leg is lateral, and beech mein there is trunk. After midbrain, it is going to be the pons. The pyramidal tract, it descends in the pons, which is ventral to the trapezium. Now, once it comes to the pons, it is going to be scattered in the form of bundles. And that scattering is because of the presence of the pontine nuclei. So, it is going to be scattered because of the pontine nuclei coming down to the medulla. While coming out of the pons, the scattered corticospinal tracts, they will now reunite in the form of a bundle. Okay, pehle they were scattered in the pons. Now once they come into the medulla, they can again be reunited in the form of thick bundles. These bundles will form a bulge anteriorly, which is called as a pyramid. And because they form a pyramid, this tract is called as a pyramidal tract. This is also an MCQ, that because the descending tract, that is the corticospinal tract, it forms a bulge जिसको हम बोलते हैं पिरामिड. कहां पर? मेड्यूला में. इसीलिए इसको बोला गया है pyramidal tract. 80% of these fibers, they are going to cross. So once they form a bulge in the pyramid, they're going to cross. The cross fibers will descend down, and 20% of the fibers will be uncrossed. And this crossing, 80% fibers are crossing. It is also called as a major motor decussation. So when I was teaching you sensory tract, the dorsal column, I told you that behind the medulla, there is sensory decussation. So here you can see anteriorly they are forming a bulge, and this is a motor decussation. Now in the spinal cord, so we've seen internal capsule, midbrain, pons, medulla, and now the spinal cord. So in the spinal cord, the crossed fibers, which will form the lateral corticospinal tract, which is also called as the cross tract, also called as the indirect tract. It extends down through the spinal cord, extends entirely down. So it is going down till the end of the spinal cord, and at each segment of the spinal cord, some of the fibers will leave and they will end either directly on the anterior horn cells or via the interneurons. So this is going to extend all down throughout the length of the spinal cord, and niche jate jate jate, the fibers will keep on ending on the anterior horn cells either directly or via interneurons. And once it has crossed, after forming the pyramids, now there will be no crossing. Now, if you see the termination of the lateral corticospinal tract, 55% of the fibers, they end in the cervical region of the spinal cord, 20% in the thoracic, and 25% in the lumbosacral region. So the lateral corticospinal tract is a longer tract as compared to the anterior corticospinal tract. 55% termination in cervical region, 20 thoracic, and 25 lumbosacral. Now we have seen that 20% of the fibers, they do not cross after forming the medullary pyramid. So they are descending down in the same side, or on the same side, or on the ipsilateral side. They are going to form the anterior or the uncrossed, which is also called as a direct corticospinal tract. Now the question is that whether these fibers cross or decussate. So the answer is yes, that these fibers, they are also going to cross the midline, but they will cross at the spinal level. So they are not going to cross at the level of pyramids, but they are going to cross at the spinal level. This tract does not extend beyond the lower cervical region or the mid-thoracic region. And you will see that the maximum fibers are in the cervical region up to mid-thoracic. So the anterior corticospinal tract is comparatively shorter than the lateral corticospinal tract. The lateral crosses after formation of the medullary pyramids, and the anterior crosses at the termination level, that is at the end of the spine, that towards the spinal cord. That means all the fibers are going to decussate, whether it is your lateral, whether it is your anterior. However, lateral will decussate after pyramids, and the anterior will decussate at the spinal level. Now, you can see beautifully shown over here the corona radiata. This is what is the fanning, which is called, passing through the posterior limb of the internal capsule, coming towards the midbrain and getting scattered in the pons. This is what is the scattered in the form of in the pons, where these scatteration was because of the pontine nuclei. Now, the long fascicles in the pons, they are again going to be bundled together over here in the pyramids. And see, this is the crossing. Those which are crossed after the pyramids will form the lateral. Those which were on the same side will form the ventral corticospinal tract. The functions, you know, that both of them, they are going to perform voluntary activity, okay, or the skilled voluntary movements. The lateral corticospinal tract, it ends on the lateral group of anterior horn cells. Therefore, it is called as lateral, because when you study the ventral horn cells, there is lateral group, medial group, isn't it? So lateral group may they are ending, and they are mainly controlling the voluntary muscles of the distal limbs. That is more fine, precise, or a skilled work. For example, you are buttoning a shirt. So when you are using more of the distal limbs, that is lateral corticospinal tract, which is controlling the distal limb muscles, whereas the anterior corticospinal tract, which ends more towards the anterior, or you can remember anteriorly, which is running more anteriorly and ending on the medial group of neurons in the ventral horn cells. So ventral horn cells के lateral group में lateral tract है, medial group में corticospinal tract है. This tract is also controlling the voluntary muscles, but mainly of the trunk and mainly of the proximal muscles. So it is mainly controlling your gross movements and your postural adjustments. So the axial musculature is by the anterior corticospinal tract, and the distal muscles is by the lateral corticospinal tract. So both of them are performing skilled voluntary movements, but which muscles they are controlling is the difference. And finally, remember that they also form a pathway for superficial reflexes, like your abdominal reflex, like your plantar reflex. And therefore, in the upper motor neuron type of paralysis, the deep tendon reflexes are exaggerated, but the superficial reflexes are lost. So this is the reason that upper motor neuron with the deep tendon reflexes are exaggerated, but the superficial reflexes, they are lost, because the pyramidal tracts, they form a pathway for the superficial reflexes. This is a very, very important take home message. Now, these fibers, they definitely, they end either on the alpha motor neurons, gamma motor neurons, so they can excite these neurons directly, but they can also end on these alpha motor neurons via interneurons. That means they have got both excitatory and inhibitory control over the anterior horn cells or over the ventral horn cells of spinal cord. Because they are communicating through the interneurons, the precise control is possible. The regular excitation or inhibition when and where needed is possible. Finally, you must always know that the most common site of lesion for the pyramidal tract is internal capsule. It is mainly because of interruption of the blood supply, and it is going to result in loss of function of the opposite side of the body, leading to an upper motor neuron type of paralysis. So if it is hemiplegia, it is total paralysis. If it is hemiparesis, it is weakness. And what is the term called as stroke? It is ruptured blood vessel that hemorrhages into the brain, or there is a thrombosis of a major blood supply to the brain. Again, it is going to result in hemiplegia or hemiparesis. Most common site is internal capsule. So, pyramidal tract, one of the very, very important LAQ, its course, termination, and applied. So, this is all for this lecture. Thank you, and always keep a happy learning.